Good morning. I'm Barry Trachtenberg, and I want to welcome you to Houston Methodist DeBakey Heart and Vascular Grand Rounds. We have a great talk today. Now it's my great pleasure to introduce Dr. Anna Barac. Dr. Barac is an Associate Professor of Medicine and Oncology at Georgetown University and Director of the MedStar Heart and Vascular Institute's Cardio-Oncology program. She is the immediate past chair of the American College of Cardio-Oncology Council and a co-director of the ACC's live course on cardiovascular care and oncology patients. Dr. Barac serves as an associate editor of JACC Cardio-Oncology and the Journal of Cardiovascular Translational Research. Her clinical and research interests focus on the mechanisms and the diagnosis and the treatment of cancer treatments in cardiovascular care. She's internationally recognized as a thought leader in cardio-oncology, and she has authored countless publications in the field. And it is a great pleasure to have her here to discuss left ventricular dysfunction and cancer treatment in 2020. So welcome and thanks for being here.
Barry, it's a true honor and a pleasure to be virtually with the Methodist DeBakey community. I will try to focus on left ventricular dysfunction, and these are my objectives. We will start by definitions, which are critically important, and as you will see, evolving on LV dysfunction, both associated with conventional and novel cancer therapeutics. I will cover professional society recommendations in this space, and we will talk about the growing cardiovascular needs in oncology patients during cancer treatment continuum. This is, and I will try to emphasize what is sort of new and what is old. And old in this field, you're talking about 5-10 years before. So cardiovascular disease and cancer are two leading causes of death and morbidity worldwide. And while we train and specialize as cardiologists and oncologists separately, these two diseases have more overlap than we previously knew. So as Dr. Trachtenberg knows very well, there is a number of professionals around the country and the world who are increasingly seeing these patients. And this is a group that got together through the American College of Cardiology around 2011 and 12 and put forward a question, what is happening? We did an environmental survey at that time to understand how can we advance patient care in this space. These are the common components that we try to put forward with respect on what needs to happen to advance care, including basic translational clinical research, inclusion of cardiovascular endpoint in oncology clinical trials, advancing education and training. And I want to put that in a stark contrast of how just a year later my clinic looked like. So this is how rapidly cancer treatments are growing, and this is also how this illustrates how rapidly we are realizing new cardiovascular phenotypes that mostly novel cancer therapeutics can have on cardiovascular homeostasis. Since we have only 1 hour, we are going to focus on heart failure, and you will see that that will not be enough, but I think it will give you a glimpse of what we've done and where we are going. So we will focus on LV dysfunction and heart failure as an effect of cancer treatment. I want to start with some changes. So in 2015, we were still using definitions such as type 1 and type 2 cardiotoxicity. I hope to convince you today that it is really outdated. It made sense when it was originally derived. It presented type 1 as a typical anthracycline-associated cardiotoxicity, which was thought to be irreversible, characterized by fibrosis on biopsy and related to cumulative dose of anthracyclines. Of that paradigm, I think the only component that is still standing is the cumulative effect, which is not correct for novel cancer therapeutics. But many other things really do not make much sense. So type 2 was designed to describe trastuzumab toxicity, and through the case in today's presentation, I'll show you that there is a lot of overlap and approaching when we have many newer agents. So we cannot call a new type of cardiotoxicity every time we find a new agent. So as I mentioned, LV dysfunction can be associated with a number of agents, and we are going to start with anthracycline and HER2-targeted therapy through this case. This is a patient of mine, 48-year-old woman who has a history of hyperlipidemia and family history of coronary disease. She's diagnosed with stage 3 left breast ductal carcinoma. Her recommended therapy, and this is pretty standard almost around the world with slight differences with the type of anthracycline, but she was recommended to receive neoadjuvant systemic chemotherapy, which included dose-dense adriamycin and cyclophosphamide. One important thing for all of you who do not see these patients every day, the abbreviations frequently reflect trade names as opposed to generic names, and that's why sometimes they don't make sense. So A here stands, it's not AC for doxorubicin, adriamycin is doxorubicin, C is for cyclophosphamide, this is Taxol, trastuzumab and pertuzumab, and again, HP reflecting their trade names. Dose of 240 milligrams per meter square. That's followed by surgery, 1 year of adjuvant trastuzumab and pertuzumab and left chest radiation. Standard, she will undergo standard routine baseline assessment of LV function because her treatment includes 3 potentially cardiotoxic agents, including doxorubicin, trastuzumab, and pertuzumab. And as you can all tell, this is a normal LV systolic function of 60%. If we do strain, it was normal at minus 24%, and 3D measures corresponded to the 2D ones with good images. So she completed her first part. To remind you, now she has received 4 cycles of doxorubicin and an initial part of trastuzumab and pertuzumab. She also has had mastectomy with with the implant, the tissue expanders, which, of course, as a result, many of you who are imagers and who haven't seen breast cancer patients will say, well, this doesn't look like the same echo. And the reason for that is that our echo windows have changed due to the reconstruction and implant placement. She has now developed left bundle branch block, and she has reduced LV systolic function. On exam, she's asymptomatic and does not have volume overload or symptomatic heart failure. So these are the clinical questions that we will try to cover in today's talk. What is the diagnosis? I think all of the above, this is one of the type of the questions where all below is correct. This could be called cancer treatment-related cardiac dysfunction. I told you that it's going to be hard to call type 1 versus type 2 because frequently these agents are given together. So in sequence one after another, meaning doxorubicin and trastuzumab. And we can also call it asymptomatic LV dysfunction. And the heart failure specialist, such as Dr. Trachtenberg, could say, well, this is now my stage B heart failure. Patient will ask you if we could have predicted or prevented it. She may ask about treatment and prognosis from cardiovascular standpoint. Is this drop in ejection fraction reversible? An oncologist will certainly ask can and when she can resume cancer treatment, because you will recall that in order for this to be curative approach, she needs to, and to have good outcomes, she needs to receive another year worth of targeted therapy. So let's talk about evolving definitions. When we had only anthracyclines, and that was in the 70s and 80s, the definition of cancer treatment-related injury was heart failure signs and symptoms. We started imaging and we realized that reduced ejection fraction was a negative predictor, and those studies were mostly done by MAGA or ERNA. However, definition of toxicity was defined by symptoms. When trastuzumab, which is a monoclonal antibody to HER2 receptor, came along, trials were done that investigated changes in LV systolic function with trastuzumab. The reason for that was a high symptomatic toxicity in the initial trials. So those were the first oncology trials that introduced the concept of asymptomatic LV dysfunction as a criteria for toxicity and also as a criteria to stop treatment. From there, FDA took the definition and created a definition of more than 16% drop in ejection fraction in absolute values from pre-treatment values as a definition of cardiac toxicity. Finally, very well known, one of the first documents talking about imaging, cardiac imaging in oncology patients, led by Juan Carlos Plana, adopted the FDA definition with a slight modification of LVF of 53% being defined as normal based on our newer ASC guidelines on LV dysfunction. So all of these definitions, as they evolved, caused a lot of controversy, and I think I'll try to describe why that is and what the path forward could be. So when we started in 2011 as a group in the ACC, one of the criticisms was, well, there's really no guidelines. We don't know what we are doing. There is a little in the literature. Well, one needs to be watchful with what you wish for. So that's the document that I just mentioned. In 2016, Europeans came forward with a position paper, which was now updated in 2020. And American Society of Clinical Oncology in 2017 published a guideline. So in 2019, Dr. Trachtenberg will know that at our last conference in DC, one of the main criticisms was, well, we have too many guidelines and they do not necessarily speak the same language. I'll try to, I'm optimist by nature, and I'll try to bring them together. I think that they have much more in common than if one is willing to look into the granular and a big picture together. So I'll focus mostly on the ASCO guideline because one of the major challenges in this space is to have a common language and to be able to communicate with oncologists who by definition see all of these patients. We tend to see the tip of the iceberg, the patients who present with symptoms or like our patient with asymptomatic dysfunction when we watch for it. So ASCO guideline was a multidisciplinary effort, and I served as the ACC representative, but you can tell there were a number of cardiologists, family medicine, patient representative, AHA representatives, as well as other societies. It addressed 5 clinical questions, and it started with the question of who are the cancer patients at risk for cardiac dysfunction. One very important part of this guideline is to consider the question in the setting of cancer treatment continuum. That is novel. We do not have this concept in traditional cardiology guidelines, meaning that you can ask the same question at the beginning of the treatment and during treatment, and you will see that there are different answers. So these are the preventive strategies before therapy, and then there are preventive strategies during therapy. The same imaging during treatment and imaging after treatment. There are differences in recommendations, and you will see very shortly why. So let's first start who are the patient at risk, and I'm going to try, in order to cover this quickly, really focus mostly on the patient that I just showed you. So what do we know? And this was based on the rigorous literature review. The patients who received lower dose anthracycline, in this guideline defines it as less than 250 milligrams per meter square. As I just mentioned today, in clinical, practical way, this is your universe of patients who are diagnosed with breast cancer and will happen to receive doxorubicin. That's a standard dose of 240. So they will all fall in this lower dose anthracycline category, followed by trastuzumab as a sequential therapy, would still be considered high risk for cardiac dysfunction. Very important when you read a guideline is to know what is it that the guideline is not telling you. And it's not telling you anything about anything else outside of anthracycline and trastuzumab world, because we do not have good studies. We'll come to that in the second part of this talk. Let's move next. Preventive strategies prior to therapy. In a very simple way, this is what can you do differently about therapy to reduce risk. So the key word here is established alternative. The recommendation number 2 is to do a comprehensive assessment. If the patient has hypertension, treated. If the patient has diabetes, treated. The truth is we very rarely see these patients before initiation of treatment unless there is established problems such as LV dysfunction. So for those patients who do have it, the question is there established alternative? So the point of this slide is not to tell you all about the literature of what is the role of anthracycline in a high-risk breast cancer. That literature is rapidly evolving. And the point of this slide, it goes in the thanks. So Dr. Chowdang is a medical oncologist with Memorial Sloan Kettering, and I gave this similar talks about how to care of the patient with breast cancer with cardiovascular concerns. The point is for this conversation, you have to engage with the oncologist. So the question has to be, is this for this patient? Is the anthracycline needed? What is the benefit of anthracycline? And one advantage in this space, oncologists tend to have data. This is a very tightly bound curve. And what it shows is that in patients who have a triple negative disease and a high-risk breast cancer, at least in 2017, there was a suggestion of a mortality benefit and recurrence-free survival in a small percentage range. So they can give you, I'm not sure that we can give the same precision with the risk of heart failure, but this is a great place to start. The same thing is true even on a much more dramatic way for HER2 positive breast cancer. About 25% of patients with breast cancer have a cancer like our patient, which overexpresses HER2. And this is just an unbelievable growth of agents which have been developed in this space. So the point of this slide was to illustrate dramatic advances in the HER2 targeted therapy space for breast cancer, and to tell us that, to remind us that we do not have precision guide for cardiovascular effect in all of these agents. So we extrapolate a lot based on what we've learned in trastuzumab, but we will be asked a couple of questions about new agents. So we have to find a way of working forward. And examples of the names that you will hear is neratinib and TDM1. So let's move to the question number 3. Now, preventive strategies during therapy. Why is that different? Well, now the therapy is decided, meaning that the patient has started on a certain regimen. And in the oncology world, particularly in the curative setting, we will try, our main goal is to try to have that treatment completed. So those preventive strategies are mostly what can we add, what agents do we have to prevent LVEF drop and prevent symptomatic heart failure. I will skip the discussion on dexrazoxane with a brief comment. It's a very effective agent that, however, has been mostly studied in patients needing to receive high doses of anthracycline, so above 250 milligrams per meter square, and it's almost never used in the early breast cancer setting. So let's talk about something that's much more known to cardiologists. These are the examples of the randomized small primary prevention trials, all done in patients very similar like the one I presented to you. PRADA trial was done in Europe, in Oslo, Norway. It was a 2x2 factorial design randomized trial to metoprolol and candesartan with placebo. And the primary outcome were the changes in LVEF by cardiac MRI at 10 and 64 weeks. The reason for this design was CMR allows you to reduce the sample size. The main question was if the patient who is diagnosed with breast cancer undergoing treatment with epirubicin, about 25% of patients also got trastuzumab, therefore they are going to be the ones imaged at 64 weeks. What happens with LVEF at the end of treatment? There was an attenuation of LVEF decline in a very small order, statistically significant, which made candesartan a winner, although a lot of questions were asked about clinical significance of that. Manticore was a Canadian trial, so we now have a different set of agents try to prevent LVEF drop, bisoprolol, perindopril, and placebo. Here, the primary outcome, again by CMR, was change in left ventricular diastolic volume index. So the hypothesis was that these agents would attenuate the remodeling. That was negative. However, patients who happened to be in the bisoprolol group had more therapy, and that meant more trastuzumab, and this was very known in the oncology community. Finally, SESI trial done in Brazil used more rigorous endpoint by reduction in drop in EF by more than 10% at 6 months. It randomized patients to carvedilol and placebo and used only patients receiving doxorubicin, and this was a negative trial. It had 200 patients, and one of the main arguments was it was a rigorously defined primary outcome. However, and you can see there the incidences, however, that echo will not allow you to differentiate further, and that might be the reason for negative primary outcome. This is an editorial that we put forward with the two medical oncologists in JAC to accompany the first US trial published by Maya Guglin in June of 2019, where there was 468 patients, very similar to the patient that I described. One of the problems with this trial, and the trial randomized to carvedilol, enalapril, and placebo, it was positive. It was primary endpoint was negative, and positive was only in a subset population. The challenge of this trial was look at the outcomes. LVF decline was considered to be significant. So 32% of patients in the placebo arm met the definition of primary outcome. That goes back to my first point of the changing definitions. It was very loosely defined. And one of the challenges of this trial, relevant for cardiovascular imagers, there was no primary review, or there was no review or the original data. The study was done at more than 200 community oncology sites, and they used the reports that came with the local LVF reads as towards the primary outcome, which of course reduced the specificity. It also reduced what we can understand what happened with the ventricle at that time. So I would say that the lessons from primary cardiac prevention trial is that there's really no one size fits all approach. If you can try to introduce any of the agents, whether beta blockers, ACE inhibitors, as a part of the treatment of hypertension. But the guideline recognized that there was no, and was published even before those trials. I think that the recommendation still stands. There was no data to support universal prescription of any of the cardiac agents together with the breast cancer therapy. Let's move to another heavily debated question, which is what should we do about monitoring? So I mentioned before some of the FDA and the American Society of Echo document recommending imaging at 3 months, 6 months, 9 months, 12 months, again, based. And I want to quickly show you, this is how the trials look. This is what the trials for trastuzumab did in order to assure safety. When trastuzumab trials were done, this is a summary 10 years later. Severe heart failure, which in the original trial was about 20%, right now went down to 0.6% in HERA trial. This was the largest we've seen in an SABP. This is the scale that oncologists look at. So these are the changes in LVEF that now we have the data on, asymptomatic. And when oncologists see that 18% of patients dropped EF by more than 10%, that means that in the setting of clinical trial, the therapy was either held or stopped in this case, leading to the question, is this too safe? And I think this is sort of my pet peeve in this space. I feel that we've achieved a lot by imaging the patients with respect to understanding what is happening with LVEF. And from cardiology perspective, we've really achieved great safety of trastuzumab. It's a very safe drug when you use it under those recommendations. However, oncology perspective tends to be, this is too much imaging. We may be compromising cancer treatment, and we haven't proven that it really improves outcomes. So I think it also, in a big way, reduced the excitement about strain, which I think in this very nice summary by Dinesh Tavandarathan, which did a meta-analysis, I think it's showing a nice data on prediction of chemotherapy-induced cardiotoxicity. It's not one measure. You have to look at the whole picture. You have to look at the entire echo. There are a lot of technical glitches. However, in some, the drop in global longitudinal strain does predict LVEF drop later. And I think we're all awaiting the final publication of the SACORE. I'm hoping that you will invite me again to discuss SACORE with at a later on and how it changes our clinical practice. I think some data initial results were shown at the ESC virtual this year, and they're going to be coming to publication soon. But I want to move to our patient and tell you what I think is the biggest deficit today, and that is, what do we do when the patient's LVEF is down? Strain is down for sure. We couldn't even measure it because of the low images. So what do the guidelines tell us? Well, AAC guidelines say get a cardiology consult. ASCO guidelines said when it's compromised cardiac function, we also need a cardiologist. So when you get the patient, what will you do? And it's really nice that in 2020, we have 2 studies published. We've conducted SafeHeart. This was done at the MedStar Georgetown and Lombardy together with the Memorial Sloan Kettering, who joined us in the last year of the study. We've enrolled 30 patients who had stage 1 through 4 HER2-positive breast cancer, had to have documented LVEF, and the patient, like the one I showed you, was part of the study during treatment or before treatment. So de novo, coming to having breast cancer diagnosis with known LVEF dysfunction, they had to need trastuzumab or a combination with pertuzumab or T-DM1 for at least 3 months, and they could not have had symptomatic heart failure prior to this. So I'll tell you first about our study. It was really nice to see that just a couple of months after our publication, another publication came from Canada, independently designed trial, which essentially had very similar design, focused on early stage breast cancer, only trastuzumab, and had slight differences in definitions, but very similar results. So let me go through ours. This was a prospective evaluation of safety of continuing HER2-targeted therapy. We had about 40% of patients who had metastatic disease. About 55% had prior anthracyclines, and this is the HER2 therapy that they received on treatment on the trial. These are the results. The primary endpoint was pragmatic. It was a number of patients who complete cancer therapy, which was planned by oncologists, without developing cardiac event. And these are our events. So we had 2 heart failure, symptomatic heart failure events, and we had 1 asymptomatic LVEF decline that in our case was defined as LVEF going all the way down to 35%. 27 patients of 30 were able to complete therapy without events. So very similar in SCHOLAR, they had 20 patients. Their primary endpoint were the number of cycles of trastuzumab that were given after drop in ejection fraction. And this is all given with concomitant cardiac therapy with carvedilol or other beta blocker or ramipril or other ACE or ARB. Again, their choice of drugs was very similar to ours. And interestingly enough, they also had 10% of events. So 2 out of 20 patients could not complete trastuzumab. Reaching this bar means that they've completed 17 cycles. 2 patients developed events and couldn't. And I like the summary that Rich Steingart put forward in the first issue of JACC Cardio-Oncology when SCHOLAR was published about 1 year ago, that these 2 trials will allow significantly more women to be fully and thus more effectively treated for their breast cancer. And I'm thinking that many of you may see these women in your practice, and that our community experience will be able to answer further challenges or new questions that are now asking, what is the long-term potential heart failure risk, and what is the really, have we succeeded to improve both oncology and cardiology outcomes on a very long run in these patients? And we are continuing follow-up of our patients. I have been talking for more than, 25 minutes, and I have covered an example of anthracyclines and HER2 targeted therapies. I want to move to other classes of agents, and we are going to use example of a patient with melanoma. It's a 67-year-old man who was treated after diagnosis of metastatic melanoma with a first-line therapy with ipilimumab and nivolumab. 1 week after the first infusion, he had developed a rash, which is shown on this image. and was treated at home with 40 milligrams of prednisone daily. He was recommended to come in, but waited just another couple of days and then came in with progressive shortness of breath. In the local emergency room, he developed respiratory distress and pleural effusion. He was hypotensive. His EKG showed bigeminy, and he is at that point hemodynamically unstable, requiring intubation. Conventional troponin I is very abnormal at 27, with the upper limit of normal being 0.004. NT-proBNP is elevated, and CK is mildly elevated. My question and here is, what is the differential and what is the treatment? So we have to cover briefly the agents that he's gotten, and they fall into the category of immune checkpoint inhibitors. This class of drugs works very differently than other cancer agents that we've had so far, in a way that it does not target a tumor. That's why it's not specific to any given tumor. It is specific to receptors that we all have on T cells, and the tumor in general can engage. So what tumors do, they use the receptors on our T cells to down-regulate immune response. It's one of the ways how tumors make a host or a patient immunosuppressed. So what do immune checkpoint inhibitors do? They block those receptors, and they're called inhibitors of programmed death number 1 or programmed death ligand. By doing so, they essentially unleash or reactivate those T cells, and then T cells are fighting the tumor. So this paradigm was acknowledged, and this is a work of many, many people, but these two individuals shown here, Dr. Honjo and Dr. Allison, got the Nobel Prize for Medicine and Physiology in 2018 for really discovering and changing a paradigm in treatment in cancer. What is shown to the right is how many of these agents are right now in clinical trials. We do not have any examples like this in cardiology. In tiny little green bars, you will see here are the approved agents. We have about 8 or 9 agents that have been approved. In everything else is in different phases of clinical trials, from phase 1, preclinical, and phases 2 and 3. So it's essentially being tried in every single tumor, and it makes sense because of the concept, and it's certain that in your clinical practice you will see a patient who will be treated on one of the immune checkpoint inhibitors if you encounter a patient, if you are seeing patients with cancer. So this is a slide that I use for my fellows. They tell you it has to be visual. So when you see they're all MABs because they're all infusional humanized antibodies. And the key words for the receptors are PD-1, PD-L1, CTLA-4. If you see that, you have to think of itis. They activate T cells. They are going to result in immune-related adverse events, and they're all going to be inflammatory. Very frequently, pneumonitis can be seen, hypophysitis, thyroiditis. In our world, what's relevant is myocarditis, and in our patient, we suspected fulminant myocarditis. He was treated with high-dose steroids, transferred to us because of the progression of the heart block, for which he required transvenous pacemaker, and we pursued endomyocardial biopsy. This is how it looked on the biopsy. And we had a positive CD3 cells. If you are a heart transplant center like DeBakey, your pathologist who specializes in heart transplant may grade this as a rejection, grade 3, given the number of CD3 cells. And we use that notion in this particular patient in the following way. He was not improving. And after the first after the first 2 days of high doses of steroids, and he did receive antithymocyte globulin added to the steroid regimen under guidelines of our advanced heart failure team. He stabilized from the hemodynamic perspective and did rather well. He was off inotropes with improved ejection fraction within a week. He unfortunately succumbed to a ventilator-associated pneumonia, and ultimately, when he was ready to be discharged to rehab about 1.5 months later, he unfortunately developed disease progression. What is the incidence of immune checkpoint inhibitor related myocarditis? It's a rare disease. So we're not talking about 5 or 10%. We're talking about less than 1%. And these data are based on the post-hoc analysis of the pharmaceutical company safety databases. This is the initial New England Journal paper by Javed Mosleti and Doug Johnson, where they describe 2 patients very, very similar to ours, also with fatal outcomes and pathology looking almost the same as the one that I just showed you. So one stark contrast from the first case, we know nothing about this gentleman's cardiovascular phenotype before he started receiving ipilimumab and nivolumab. We also know very limited from clinical trials unless the patient had symptoms and or died, and that was felt that it might be due to treatment. So some of the information coming right now is mostly based on Tom Nealon's registry. It's a registry of a number of sites from the United States, where they put together at that time 35 cases and it grew over time. So I want to show this slide, and I often say if we need to remember one related to immune checkpoint inhibitors, I think for cardiology community in general, this is the most important one. It tells us a couple of things. So what is the time from the start of immune checkpoint inhibitor to clinical myocarditis? This is a flip side from cumulative toxicity. Here, toxicity tends to be early on. So it's typically after the first or a second infusion. And here you can say days, you can see days. Most of the events happen within first 90 days. If you know that infusions are typically every 3 weeks, that will give you a time frame. Many of them after first infusion, second, third. Very rarely you're going to have a case that patient has been receiving immune checkpoint inhibitor for 2 years and now presents with immune-related myocarditis. So what is the clinical picture? These are the abnormalities of EKG. So in most patients, EKG was abnormal, and in most patients, troponin was positive. The scale of that positivity can be very different, but very positive. This is the key point. Remember how much we were debating the definition of toxicity related to LVF? Is it down? Is it not down? Well, here you can flip a coin. This means that if you are having a patient in whom you're suspecting immune checkpoint myocarditis and your LVF is normal, that really doesn't tell you anything with respect to likelihood of him having or not having myocarditis. NT-proBNP was more positive than negative. So I'm an imager by training, and I feel that my job is to apply everything we know about cardiovascular physiology, pathology, and imaging into this new population of cancer, of patients with cancer-receiving agents. So the new advances in cardiac MRI that resulted in better and more accurate diagnosis of myocarditis can be easily applied here. It's a very important tool, and Tom Nealon also looked into this into his registry. So in this case, they're now up to 56 patients who had pathology-proven immune checkpoint inhibitor myocarditis. In a nutshell, I want to summarize this slide. T2 imaging, which signalizes edema for everybody who is doing cardiac MRI. It's a known phenomenon. And late gadolinium enhancement, which is an important marker also in myocarditis focused on fibrosis and inflammatory infiltrate, was helpful. However, it was not sensitive enough to completely exclude myocarditis. So there were cases of pathology-proven myocarditis that had negative MRI. And I really like the way how the author summarized the approach. I think it's applicable to my daily practice. If its suspicion is positive, we can do initial tests. And remember that slide from 3 slides ago, EKG, troponin, BNP, echo, to tell you about stability of the patient and the likelihood of this being clinical syndrome of myocarditis. If the patient is stable, you can have cardiac MRI. If gadolinium enhancement or there is a signal, T2 signal on STIR or parametric imaging, you can confirm the diagnosis. In unstable patients, they, like ours, you should proceed with endomyocardial biopsy together with a catheterization. However, if the CMR is negative, you should still, and the decision is relevant, you should still pursue the myocardial biopsy. I think we now are having like 2 cases every week, and there are a lot of things that go into decision of endomyocardial biopsy, so I'm happy to take questions after this. I want to go back to our original slide and some sort of foods for thought. So we've covered a couple of classes of agents. I want to, again, going back to the problem of imaging, there's a frequent criticism about over-imaging. That may be true for a very small group of patients. In vast majority of the patients who are getting conventional therapies, VEGF inhibitors, immune checkpoint inhibitors, proteasome inhibitors, we do not even know what the baseline LVEF is. So I think that has to be our first approach. And I think oncologists are increasingly interested. We have a number of examples where a patient comes with a low EF and the question becomes, is this cancer treatment-related injury, or this was before? You have your 78-year-old or 85-year-old who would not have been part of the clinical trials. So this is an area where we have to do a lot of education. This is a summary where I try to put forward why is it so that all of our professional society statements, and I think I showed you that in most part they agree with each other on the key concepts. They're really addressing mostly anthracyclines and HER2-targeted therapy. Some are including recommendations for VEGF inhibitors, but these are new drugs. The immune checkpoint inhibitors did not exist in clinical practice before around 2010. So I think there's exciting work to come forward in both understanding the phenotypes, diagnosing them, and then co-managing. So with that, I would like to conclude, and I hope that I conveyed to you that LV dysfunction associated with different cancer therapeutics is more relevant than ever. There has been a shift in paradigm to management of LV dysfunction from the pure diagnosis, calling it cardiotoxicity, and stopping cancer treatment. So I think we're moving toward joint questions. How can we continue treatment? And this is really a growing community. Thank you, Dr. Trachtenberg. I'm sure you get a lot of text calls and questions when situations like the one I showed go to you. I think every institution has one, and I'm hoping more of dedicated cardiologists to this field. And you nicely outlined my conflict of interest being the associate editor for JACC Cardio-Oncology. It's, I think, a terrific resource, and I would invite everybody to submit new science, new cases, and new knowledge to the growing field. With that, I would like to thank you and take any questions.
Thank you, Dr. Barac, for a phenomenal overview. And now, I mean, when I get questions, I'm just going to send people this YouTube video, really comprehensive. And thank you so much for giving the grand rounds today. We do have some questions, and I'm going to start. The first one is from Dr. Zogby, who says, thank you, Dr. Barac, for a most comprehensive presentation. How do you use LV strain now in management? Is similar to ASC guidelines, or are there any new changes?
I think it's a great point. I think it's similar what the ASC guidelines intended. I think we are getting there. So I use it at the beginning of treatment when the patients are diagnosed, mostly if the ejection fraction is normal and strain is abnormal. It does make me think, are we dealing with any pre-existing condition? Is there hypertension? Is there anything that I'm not understanding? Does this patient, as you know, in a non-cancer population, abnormal strain has been put forward as a stage B potential heart failure, such as in patients with diabetes. So I ask a question, do I have a room for opportunity to treat this? If the strain drops during treatment, and again, this is really, I think the main limitation is this is really limited to a small number of patients, which is HER2-targeted breast cancer, in whom HER2-targeted therapy in patients with that type of breast cancer where we have serial images. So in those patients, drop in strain, I think does make me ask that question again. I do tend to start cardio preventive medications in those. And I think that's what the SUCCOR trial tried to address. So SUCCOR trial, and I think that's what's going to perhaps make it bring the stronger message to the community. The results were presented at the European Society of Cardiology, and the primary endpoint was negative. But there were a lot of positives in the trial itself. So what was the trial? It tested the hypothesis if we use strain-guided therapy, meaning that if the strain drops, you use that as indication to start a beta blocker and or ACE inhibitor or ARB. While in patients who were randomized to the non-strain-guided therapy, they were just following by EF. So starting the patient on ACE inhibitor or ARB based on the strain reduction did not change the primary endpoint, which was the LVEF measured by core laboratory at the end of 1 year. However, there were less drops in ejection fraction over time. And in a very pragmatic, every oncologist is going to take that as a success, because your goal is to achieve safer administration of the oncology drug. So I think that many of us who are in this space are already practicing, and support was really needed. I really congratulate Dr. Marvik and Dr. Tavandirathan who led it. It ended up being really very international with a very small participation of the US sites. And I think I alluded to you why I think it was very difficult to do it in the US. I think the language and the communication with the oncologist is challenging, but I'm glad it was done. And I think it will make us use more strain to understand the phenotype. In the patients receiving other therapies, so no outside of trastuzumab and anthracyclines, I think our understanding is very limited. I think we definitely, just like any new tool that's validated and working, we should start using it in other populations. An example in myocarditis is right there. I didn't talk a lot about it because I wanted to bring the key message forward, but global longitudinal strain was a predictor. Abnormal global longitudinal strain was a key predictor of MACE among patients with myocarditis in the registry that was presented by Tom Nealon. So I think it's an excellent tool. Just like any measure, should not be looked in the isolation. And Dr. Zogby will know this really well. When you look at the mitral regurgitation, you do not look at one measure. You have to look at everything. And I take the same for strain.
So while we're on the subject of imaging, we get a lot of phone calls from oncologists. I'm sure you get this all the time. The EF is 65%. Next time they get the echo, it's 55%. Then they get it a week later, it's back to 65%. And so just in your practice and what your recommendations, what do you do to maintain consistency? Do you use biplane on all cancer patients or 3D assessment? How do we avoid this problem?
It's an excellent point. So I think that and education goes two ways. One, in the echo lab, we do have what's called like a chemotherapy protocol, or just to know, because the key is the serial imaging, and we do not have a lot of that in other clinical practice of cardiology. For example, patients with mitral or with valvular disease in general, we follow them serially, but we follow them in the setting of the clinical trial, and we all understand you cannot look only in one measure. When you send a report to oncologists, they're genuinely confused. And so we use, we encourage 3D, we encourage reporting of strain, we encourage using biplane symptoms. In many patients, just like you showed in mine, the image quality really deteriorates if it's a left-sided breast cancer and the patient has surgeries of different kinds, and it's very often not only one. So reporting in the category saying the function has changed and has remained in the normal range or has now changed into, or if you cannot see, you have to say that. So we do, I think that has improved. Education also goes the other way, meaning to tell the oncologist, this is how we are calling, this is still in the normal range, or there has been a decrease towards the mildly reduced function. And I do tend to see the patients in whom we feel there was a change, even just to consider starting the therapy.
Great. And another question we have here is, in your Safe Heart study, what were the limitations in getting patients that are on chemotherapy, that already are on a lot of treatments with side effects, on getting them on guideline-directed medical therapy? And what are those challenges, and how do you work around that?
So Safeguard actually was not that. So this was one example where oncologists and patients were very interested in participating for the following reason. Because these patients, we had to request IND from the FDA for all three drugs that we were using for oncology treatment. So we got IND for trastuzumab, pertuzumab, and T-DM1, although they were used for their approved oncology indication in the FDA label. They are approved to be given only with normal ejection fraction. So I talked to Darrell Leong, the author of the Scholar, when they were designing their study, and that's not the practice in Canada. Their regulatory bodies felt that that was not necessary, and it just speaks of the different environments. So the reason, to go back to your question here, there was a strong motivation by the oncologists to bring the patient onto a trial so that the cancer therapy can be continued. And all the patients were quite motivated. Now, with respect to tolerance of carvedilol, I thought that we were going to be able to give more of the drug. So we had a quick up titration, and it's I'm happy to share with you. And if you wanted to add this, we published in the design paper. So we had a rapid titration of the beta blocker. So when the patient would get on the trial, they would get a blood pressure cuff. We would call them weekly, and we were titrating the beta blocker, which we asked to be carvedilol. So if the patient could tolerate, and most of people were on some carvedilol, so we were going up with a dose as weekly if there was room in blood pressure, and we were really trying to not go up only in the patients who were symptomatic, meaning that mean blood pressures were in the 100s. And again, these are not patients with a very dilated hearts. The ejection fraction was solidly on the 40% range, but not less than 40 based on the Norman criteria. So in a fraction of patients, mostly on the ones who were treated for hypertension before, we were also able to add an ARB or an ACE inhibitor. The tolerance was good. It's just, it really does take a lot of effort to educate the patient, to get the buy-in. Here again, they were mostly stimulated by the desire of staying on therapy, which they needed. So it was an example of a trial where the patients wanted to be on because they viewed the drop in ejection fraction was really an obstacle from them on continuing.
Great. So I think that's all the questions we have and time we have. But thank you so much, Anna, for being here. It was a really phenomenal Grand Rounds. I think a lot of people learned a great deal from it. And thank you for battling through the technical glitches. And we look forward to seeing you in person next time. Thank you very much.
Wonderful. I really appreciate it. And likewise, I look forward to seeing that beautiful tower of Methodist in person.
Okay.
Thank you.